I'm Laura Papar, Deputy Director for the Washington-Baltimore High-Intensity Drug Trafficking Area. I'm also the Director of ADAPT, which stands for a Division for Advancing Prevention and Treatment. ADAPT is funded as the Training and Technical Assistance Division for the National HIDA program in their substance use prevention work. We have approximately 33 HIDAs across the United States, and many of them are operating substance use prevention programming strategies and some practices in various ways, shapes, and forms. And so what we'd like to do with this particular series is something a little different. This is our third series that we're launching, and we're so excited about it. We're just coming off a first round of technical webinar series to help break down concepts for folks and really establish some fundamentals and essential understanding of concepts related to substance use prevention. We've also launched a series specifically for HIDAs that entails conversations, more intimate conversations with HIDA communities and learning from one another, more in a peer-based network. But this is an evidence-based practice spotlight series. And the purpose of this series is really threefold. The first part of the purpose is really to highlight best and promising substance use prevention strategies that are out there, that exist in the literature, and many funded by HIDA. So we've invited one of our HIDAs to showcase one of the programs that they're funding today, and that's the New England HIDA. The second part of our purpose is really to help think through and understand the evidence supporting the strategies from the lens of the CCE Understanding Evidence Framework. And it really is truly a way of thinking about the evidence and just helping enhance a skill set when we do encounter various forms of evidence and trying to make sense of that when we make our decisions for selecting evidence-based strategies. The third part of the purpose for this evidence-based spotlight series is really to connect you to training and resource opportunities that will come forth from that particular strategy. And so all of that you will find within this particular series. What you can expect from this series is this. You can expect an overview and description of the strategy. Today's strategy is scope of pain. And so they will go into detail about implementing that program, and implementation considerations is another thing you can absolutely expect. You can expect a review of outcomes for each of the strategies. You can expect a very transparent conversation with either the developers or the implementers or the representative of that strategy. Today, we've got a wonderful one that you will be introduced to in just a minute. And then you can also expect direct links, dates, and contact points for that particular strategy. And so all of this is housed within our evidence-based practice spotlight series. What I'd like to do now is to thank our participants today. I'd really like to thank Jay Fallon, who's the Executive Director of the New England HIDA, and also Jack Foster from the New England HIDA for introducing us to our wonderful presenters today. It really has been such a joy getting to know them a little bit better and learning more about their program. I'd also like to thank Jamie Delano for joining us today from the National HIDA Program Office. And I'd be remiss if I did not thank our ADAPT team as usual, Dr. Patty Thursigas and also Dr. Rebecca Bates, who's going to be joining us for that thinking through the evidence piece. So a special thank you to all of them. And now I'm going to hand it over to Jamie Delano from the National HIDA Program Office. She serves as their Deputy Director and leads the prevention efforts. Jamie.
Thank you so much, Laura. I'm very excited to be here with all of you today. The importance to HIDA prevention is to use the best available evidence to inform selection of prevention programs, practices, and strategies in HIDA communities. I am, again, excited that through this series, the HIDA program can highlight some of the current strategies being funded by various HIDAs, but also to promote through this series an enhanced understanding of how to think about evidence, incorporating not just the formal research base, but also the contextual and experiential elements of our unique HIDA communities. One such initiative that you will hear about, scope of pain. New England HIDA has partnered with the Boston University School of Medicine to offer this accredited program that provides continuing medical nursing education, CME training. Scope of Pain was initially funded by HIDA discretionary funding in 2013. And now I'd like to introduce Jay Fallon, the director of New England HIDA. Jay?
Well, thanks very much, and good afternoon to everyone. I'm honored to be invited to speak regarding this relationship and partnership with BU's School of Medicine, and we believe it to be a best practice for the HIDA program. We'll keep it very, very simple here. Our relationship, as Jamie alluded to, with Scope began in 2013. Now, why did that happen, and how was it implemented? What we now recognize as an epidemic in heroin overdoses and overdose deaths was being faced by law enforcement back in the early 2000s, 2010, 12, 13. And that was certainly recognized by our New England HIDA Executive Board. We were directed by them to be proactive in order to engage with prescribers and the medical community as an outreach. In essence, law enforcement was seeking help. We were becoming overcome by events. It's very common now to say we can't arrest ourselves out of this problem, but it wasn't so common back. Made aware of Scope's existence through the Boston University School of Medicine. Facilitate a phone call to them and offer to help. The rest is history. And I have to tell you, we were welcomed with open arms by the folks from BU School of Medicine. This serves as New England HIDA's prevention effort. The specifics of the Scope program will be presented next by Dr. Dan Alford. But here we go. Jamie Delano said that we were first funded in 2013 through discretionary funding. But in 2019, we fast forward to 2019, and Scope is now a New England HIDA baseline funded prevention initiative. Now, why do we do this? We see this. New England HIDA sees clinician and prescriber education as a great investment. And that's what we're all about, right? We invest in partnerships. Why we do it? Our demand reduction, this is contribution, okay? What does it mean to us? HIDA is all about partnerships. Federal, state, local, law enforcement, under one roof, addressing the greatest threat in your area in a task force environment. Heroin and now fentanyl abuse cause the HIDA program think outside the box and include federal and state and local public health agencies, CDC, state and city departments of health into this partnership to address the greatest threat. The greatest drug threat, again, under one roof in a task force environment. We've been pretty successful using that recipe. This partnership has resulted in a rethinking of attitudes on the part of both public health and public safety partners as the true partnership evolves. And we could talk for hours about what a true partnership is. And a true partnership isn't me telling my partners what they should do, or vice versa. It's a give and take on both sides, on all sides. Everybody brings something to the party, so to speak. And certainly public health and the Scope program brings something to the party. It's no longer law enforcement telling prescribers, stay in your lane, this is my problem, or that's your problem. Drug abuse, be it heroin, be it fentanyl, be it cocaine, meth, whatever it is, okay? And overdose deaths, etc., are recognized not as your problem or my problem, but it's our problem. And we, that is the big we, public health and public safety, work diligently in order to address it. There's a lot of HIDA folks from across the country here. Do your homework and establish a relationship with the best academic institution in your area. You'll not regret it. Trust me, you'll not regret it. Embrace the partner and value the partnership. The smarter we get, the better we'll be. And thanks to everyone for this opportunity. I'm going to turn it over to Patty now.
Laura, Jamie, Jay, thank you for setting us up and describing the importance of this series and partnerships. And we're very excited to present to you, Dr. Alford, to present on scope of pain. Before we do that, I did just want to share a couple of housekeeping tips for how you can maximize your participation and engagement with us today. You will notice that below my image on your screen, there is a box that says ask a question. We encourage you to send questions along the way. We're really hoping to encourage and have a number of discussions that are happening throughout the series today. So please submit any questions, thoughts, comments that you may have in that. We'll be synthesizing those and pausing at a couple different time points throughout the presentation to get to those. If you have any technical assistance needs, you'll notice that there are 2 points of contact on the slide in front of you. So feel free to contact us at either one of those numbers and or email addresses that you see there. Also, below the Ask a Question box, you'll notice a little tab that says Resource Supplement. If you select that option, you will have access to a downloadable resource supplement that will include the slides from today's presentation, a number of the resources recommended by the presenter and the ADAPT team. And many of those resources will be presented here today. So without further ado, I would like to go ahead and present Dr. Alford. So Dr. Alford is a professor of medicine, associate dean of continuing medical education, and director of the Scope of Pain program at Boston University School of Medicine. He's on staff in the section of general internal medicine and director of the clinical addiction research and education unit at Boston Medical Center. He's also medical director of the BU Evidence-Based Expert Student Training Project and the Boston Medical Center's Massachusetts Expert Training and Technical Assistance Program. He is past president of the Association for Medical Education and Research in Substance Use. He is director of the BUSM Immersion Training Programs in Addiction Medicine, funded by NIDA. In 2011, he was recognized as a champion of change by the White House. In 2014, he received the AMA Award for Health Education, and in 2016 was awarded the Educator of the Year Award by the American Society of Addiction Medicine and the Award for Distinguished Contributions to Behavioral Medicine by the American College of Physicians. His clinical, educational, and research focus on opioid use disorders and safe and competent opioid prescribing for chronic pain speak for themselves. We're very lucky to have him and his expertise with us today. So Dr. Alford, I'll go ahead and turn it over to you.
Well, thanks for having me. I'm delighted to be here presenting to you, and thanks for the introduction. So let's get started. So first, in terms of disclosures, so I am a course director for Safer Opioid Prescribing, Continuing Medical Education that's funded by unrestricted educational grants, but these are awarded to Boston University, and I don't receive any direct payments from industry for these activities. So the roadmap for my talk, which will be split up into different sections. I'm going to give you some background, and the background is really from the primary care provider, primary care physician's perspective. So it's information that you may have heard before, but it's coming from my perspective. Then we'll take questions if you have some. Then we'll talk about this national education strategy that Scope of Pain is part of. I'll talk about measuring success. And then before moving on to Scope of Pain in particular, we'll take some more questions if there are any. But then I'll move on to what is Scope of Pain, how did we evaluate it, and then some additional thoughts. So background. So I think we need to look back to move forward, and there's lots of, should I say, blame or reasons why we ended up in the opioid crisis that we ended up in. And you know, some people say that the Joint Commission's 2001 pain standards, which were termed the fifth vital sign, that is that every patient should have their blood pressure and heart rate and respiratory rate measured, but they should also have their pain measured as a vital sign. And along with that were patient satisfaction surveys. That is, asking patients after they've been hospitalized or after they've been seen in clinic, what's their satisfaction with their pain care. That some of that may have drove the move towards an opiocentric approach to treating pain. That is, being overly focused on the use of opioids. There certainly was over-marketing of opioids as being safe and effective. Society has unrealistic expectations about opioids, and oftentimes you hear the term painkillers, and we really have nothing in our armamentarium for treating pain that's a painkiller. Also, lack of training, which is really what Scope of Pain is focusing on, that is addressing the healthcare provider lack of skill and knowledge. Also, clinician phobia around confrontation. So if a patient is on opioids and you want to make a change, namely tapering them off opioids because you don't think they're benefiting the patient or they're harming the patient, it can be quite confrontational, even though we try our best not to be. There's a financial misalignment favoring the use of medications. It's a whole lot easier for me to prescribe a medication than to send a patient to non-pharmacologic treatment like acupuncture or behavioral therapies. Lack of comprehensive pain management programs. There's really no place to send patients for a comprehensive multimodal approach for pain. It's really, really, really difficult to measure what we're trying to treat. That is, are we making an improvement in benefits and are we causing any harm? As opposed to things like blood pressure and diabetes, where I have very objective measures for benefit and harm. With pain and the treatments for pain, it's really hard to measure whether or not we're doing what we're hoping to do. It's often difficult to distinguish inappropriate pain seeking from inappropriate drug seeking. So it's, inappropriate drug seeking can look very much the same as appropriate pain relief seeking. They can both look equally desperate. And then opioids are actually the last choice. You've tried everything else, and opioids are tried. And because opioids don't have a ceiling effect, that is, there is no maximum dose to get some potential pain relief, people ended up on very high doses of opioids, as opposed to things like ibuprofen and acetaminophen, where there is a clear milligram maximum that you would never go beyond because there's no additional pain relief. We know that patients who are end of life or in palliative care continue to get at least some benefit with higher and higher dose of opioids as long as they can tolerate them. Opiate analgesics are actually quite important. They do a lot of things in the central nervous system and the nervous system to turn down the pain signal. They turn on an inhibitory system. They prevent the transmission of the pain signal. They inhibit some of the transmission of pain from the pain fibers to the spinal cord. And they also inhibit the activation of the pain receptors or nociceptors. But we know that there's variability in how patients will respond to an opioid, that not all patients respond to the same opioid in the same way. And part of this has to do with our different genetic makeup. That is, that not everybody that's listening today or people that you know have the same opioid receptor system. That there are lots of what's called polymorphisms to that receptor system. So one of you may respond better to one opioid than another. And it's not only at the receptor level, but it's also how we metabolize and how these opioids act on our receptors and ion channels through these what's called single nucleotide polymorphisms, or SNPs. So it's really just to say that opiate analgesics do a lot in terms of turning down the pain signal, and that there's variability in how one patient will respond versus another. But we also know that they activate the reward pathway. They make us feel high sometimes or euphoric. And so there's a major risk to these molecules or medications. Now, this is really the elephant in the room, right? That is, the problem is there's no evidence that opioids work for chronic pain, according to guidelines released in 2016 by the CDC. Now, this was a statement by a reporter in Mother Jones in April of 2018. And if this was really true, then I could just stop my talk right now, because let's get rid of opioids. But you'll learn that it's not true. And I'll tell you what is true. So what is the efficacy of opioids for chronic pain? And we have some meta-analyses, which are really studies taking a bunch of well-done studies and kind of putting all their data together and coming up with conclusions. And when you look at opioids versus placebo, just looking at high-quality evidence, there is statistically significant improvements in pain and functioning with opioids versus placebo. What about opioids versus placebo for nerve-related pain, which is really hard to treat? Well, those studies, unfortunately, are only low to moderate quality, but they did find clinically relevant pain relief and reduction of disability with opioids versus placebo. What about opioids versus non-opioids like ibuprofen or acetaminophen? Again, those are low to moderate quality studies, and they found similar benefits. So, opioids may not be better than some of these other medications, but they certainly work better than placebo. What you will notice, though, is that these studies only had about a 6-month follow-up at best. So patients end up on opioids for years, 5 years, 10 years even. And really, we're kind of in an evidence-free zone when we start to get above 6 months. We really don't know because it hasn't been studied. There was one very high-quality study that looked at opioids versus non-opioids for over 12 months, or a longer-term study, and they found no benefit of opioids versus non-opioids for improving musculoskeletal pain-related function. That's an important study because it was longer term and it was a randomized controlled trial, which is the highest level evidence you can get. However, when you look at who was included in this study, it turns out that any patient that was already on an opioid was excluded. So that kind of self-selects a certain group of people. And of those that were eligible to enroll in the study, 89% said no thank you. So of the 11% who were not already on opioids, who said, sure, I'll enter into the study, there was no benefit of opioids over non-opioids. So it's a very select group, and maybe not necessarily the patient who's sitting across from you. And in summary, the efficacy and safety of chronic opioid therapy, that is more than 6 months in duration for chronic pain, has been inadequately studied. It may benefit or maybe not. It just hasn't been studied. What's been happening with opioid prescribing trends? Well, as you know, from the 1990s, we started seeing an increase in opioid prescribing for many of the reasons that I mentioned earlier. And it pretty much peaked in 2011 and it's been declining ever since. And is this decline more judicious prescribing, which I hope, or is it more fearful prescribing? It's probably a combination of both. Where we should be in terms of the volume of opioids on a population basis, nobody knows. Yes, there are countries that prescribe a whole lot less opioids than we do, but, is that the right amount? Who knows? And I like to think of it less on a population basis and more on the individual patient level basis. What about overprescribing for acute pain? And I'll explain why I'm focusing on this for a moment. First of all, it's been looked at both in the emergency departments and postoperatively. In this one study looking at the emergency department, where they were looking at opioid use for back pain, kidney stones, fractures, dislocations, and other kind of musculoskeletal injury, turned out that 93% of patients in this study had leftover pills. So they were prescribed too many pills. 52% of the pills in total were unused. So again, too many pills were being prescribed. From different surgical procedures, from different studies, we see that on average, more than 70% have said that they used half or less of the pills that were prescribed after surgery. So why is this important? It's important because when you look at the National Survey on Drug Use and Health, which is a national survey where they ask people about drug use, of those that said, yes, I misused a prescription opioid, that is either it wasn't prescribed for me or I was prescribed, but I used it in a different way than the way it was prescribed. When they asked them, well, where did you get that prescription opioid that you misused? If you look at the gray part of this pie chart, which is 51%, it was given or bought from or took from a friend or relative. That is, that more than half the people who misused a prescription opioid in this national survey got it from a medicine cabinet, likely. Again, because there was leftover pills from surgery, from an emergency room visit, or people with chronic pain who were not storing it safely. What about trends in opioid overdose deaths? Well, this is probably data that you know as well. That is that from the 1990s, when we started becoming much more focused on using opioids for pain, the natural and semi-synthetic opioids, which is that light purple line, really made up the majority of opioid-related overdose deaths. But that was taken over by heroin. Starting in 2011, we started seeing an increase in heroin use and heroin-related overdose deaths. And now, as you know, it's the third wave, which are the majority of opioid-related deaths are from synthetic opioids that are being manufactured illicitly outside of this country, like fentanyl analogs. I think, some of the press around the opioid issue has kind of decreased with all the attention to COVID. However, the overdose deaths, the latest data that we have from the CDC, they were greater than 83,000 deaths during June of 2019 to June of 2020. It's the highest number in a 12-month period, and there was a 21% increase compared to the previous year. So it's still a huge problem, obviously. But, when I start thinking about, well, if a patient isn't benefiting or they're at harm and I'm going to decrease or taper their opioid, is there a risk to that? And so people have started looking at opioid discontinuation risks. And this was a study of over 1 million US veterans with an outpatient opioid analgesic prescription that they were on for over 2 years. So these were these patients with chronic pain on long-term opioids. Opioid discontinuation was associated with an increased risk of death from overdose or suicide, regardless of how long they were on the opioids. So remember, everyone was on at least 2 years, but some were on much longer. The risk increased with the longer the patient had been prescribed opioids, and patients with SUD or substance use disorder or addiction and mental health diagnoses were at the highest risk for overdose and suicide. So discontinuing opioids in someone who's been on them chronically is not a benign process. We need to be careful and consider these patients high risk. How do we prescribe opioids for chronic pain in a safer way? We use what's called universal precautions, which is assuming that every person who's prescribed an opioid has at least some risk, that it's impossible for us to determine a person with no risk. So we assume everyone has risk, so we use universal precautions. And that includes risk stratifying people using a misuse assessment. That is, not every patient has the same risk. Using agreements, patient-provider agreements, so that patients understand what our obligations are and we understand what theirs are, and there's an agreement. It's an education document. And then medication management. Opioids should never be first-line therapy. We should be prescribing the lowest effective dose, but we should use caution with any dose. And really try to avoid doses more than 90 milligrams of morphine milligram equivalents, which is kind of a way to standardize the opioid dose, MMEs. And to try to avoid dangerous combinations, that is prescribing opioids with other sedatives like benzodiazepines. Frequent face-to-face visits and documenting the risks and benefits, and then using risk mitigation, monitoring for adherence and addiction and diversion strategies like urine drug testing, counting pills, making sure people are taking the medication exactly as prescribed, checking the prescription drug monitoring program data, and co-prescribing naloxone. Now, this is all easier said than done. These interactions are quite complex from a physician-provider. It's actually physician-patient communication. And this was an op-ed piece written by a general internist that works at New York University at Bellevue Hospital, published in the New York Times. And I think it really captures a lot of what's going on here. And what does she say, Dr. Ofri? Undertreating pain, we're admonished. It violates the basic ethical principles of medicine. On the other hand, we're lambasted for overprescribing pain medications, creating an epidemic of overdose deaths. For patients with chronic pain, especially those with syndromes that don't fit into neat clinical boxes, being judged by doctors to see if they merit medications is humiliating and dispiriting. This type of judgment, with its moral overtones and suspicions, is at odds with the doctor-patient relationship we work so hard to develop. And then she gives a little scenario. As Mr. W and I sat there, sizing each other up, I could feel our reserves of trust beginning to ebb. I was debating whether his pain was real or if he was trying to snooker me. He was most likely wondering whether I would believe him. Now, compounding all this, and I had mentioned this earlier, there's an education gap that U.S. medical schools average 10 hours of pain management education, with only 30% offering opioid prescribing education at all. 82% of primary care physicians rated their undergraduate medical education in chronic pain as insufficient. 55% of primary care physicians rated their chronic pain training in residency as insufficient. And only 34% of physicians that were polled felt comfortable managing patients with chronic pain, and only 1% found doing so satisfying. So there's really a lot of work to be done around education. So before I move on to a national education strategy, which Scope of Pain is part of, I want to pause to see if there are any questions.
No questions at this time.
Okay. Let's continue.
I take that back. One just
Okay.
came in. In your experience, how effective are state prescription monitoring programs to combat doctor shopping or other things for controlled substances?
Yeah, so that's something I've thought about a lot, because a lot of states like Massachusetts requires me to check the PDMP every time I write a prescription. And I will tell you that the yield, that is, finding stuff on the PDMP that's going to change my practice, is essentially nil, nothing. I can't remember the last time that I found anything on the PDMP that was unexpected. And I didn't point out in that pie chart where 51% of people got their opioids that they misused from family or friend. There's actually a piece of that pie, 1.4%, I think, said they got it from going to multiple doctors. So it's really a small piece of the puzzle. It's hard for folks who are not busy doing clinical work to understand, why wouldn't you want to know if someone's doctor shopping? And it's like, it's not that I wouldn't want to know, but I wouldn't want to do any test like checking the prescription drug monitoring program as a test that isn't going to give me anything meaningful. Okay, you could say, yeah, it's reassuring that your patient is doing the right thing, but is that really well spent time for me or the person that I'm delegating to look it up? So you can see that I have mixed feelings about it. I think it's an important tool, certainly where you don't have a relationship with a patient, like in the emergency room, or, and I think that's probably higher risk prescribing, or for me with a new patient who's coming in saying, my doctor retired and this is what I'm on for medication. So I think there are absolutely really important uses of it. But for a state to mandate that I check it every month, every single time I write a prescription, I think that's a little over the top. That's my opinion. Any other questions?
Thank you. That's it for now.
Okay, so let's talk about one strategy for addressing this education gap and all of the issues that I've just brought up. And this strategy is from the FDA, right? It's the Opioid Analgesic Risk Evaluation and Mitigation Strategy. So you're going to hear me say REMS a lot, opioid REMS, and that's what this is. It's a national education strategy. So it's a unique program. So the FDA requires a lot of drug companies, pharmaceutical companies, to develop REMS programs for their single medication. That is, the medication has risk, so they need to create education around that risk so that prescribers do it safely. This is unique because it wasn't just about one medication. It was about a class of medications. It wasn't about one pharmaceutical company. It was about every pharmaceutical company that manufactures opioids. So the overall goal of this REMS program was to reduce serious adverse outcomes, namely addiction, unintentional overdose deaths, from appropriate opioid prescribing while maintaining patient access to pain medications. So there was this two-sided part to it. One, maintain access because some patients do benefit, but let's try to reduce the serious adverse outcomes. And how did they go about this? Well, first, the federal government. So in 2012, the FDA mandated this class-wide opioid REMS, and they created a curricular blueprint. So the education that was going to be paid for in this REMS was going to be based on a blueprint that they developed. The REMS program companies, that is the manufacturers of opiate analgesics, provided unrestricted educational grants to accredited continuing education providers like Boston University. So we had to apply for the grant. And then the continuing education accreditors like the Accreditation Council for CME, the ANCC, which is the American Nurses Credentialing Center, the American Council for Pharmacy Education, the osteopaths, the family practitioners, were responsible for auditing and capturing and reporting data based on this program. The bottom line was the manufacturer's funding of the education was mandatory based on the FDA mandate. Prescriber participation, however, was voluntary. There was a lot of discussion about making prescriber participation in this program mandatory, but we'll talk a little bit more about that later. But it was voluntary. So the FDA curricular blueprint was quite comprehensive, or it's comprehensive now. It talks about the basics of pain management, mechanisms, and how do you assess pain, and creating a treatment plan. Non-pharmacological treatment needs to be talked about. Not only pharmacological, meaning opioids, but non-opioid pharmacologic treatment. Managing patients on opioids for both acute and chronic pain. Identifying behaviors that make you worried about addiction or an opioid use disorder and managing those, and learning how to taper opioids safely, and then really diving into addiction medicine and getting an understanding of what that's all about. There were no limits or restrictions on what could be included in these trainings as long as all of the elements of the blueprint are covered. So there was some flexibility from our perspective at Boston University to add things if we wanted to, but we needed to cover everything in the blueprint. So there was misinformation, and I'm, kind of focusing here on Mother Jones, but it was an article that brought up a lot of important misinformation, I think. And the title of this story was, "Doctors Receive Opioid Training, Big Pharma Funds It, What Could Go Wrong?" And a quote from this article was, "For opioid makers, the continuing education courses for doctors, one of the most important marketing tactics that they have," says one pharmacology professor. "It doesn't look like advertising. It doesn't look like promotion. It looks like education." Well, if that's the case, I agree. This is terrible. This REMS program is a terrible idea. However, does opioid REMS equal marketing? And the answer is no. The hallmark of accredited continuing medical education is actually independence from promotion or marketing. ACCME, the Accreditation Council for CME, standards ensure that accredited CME is relevant, practice-based, and independent of commercial influence or bias. Companies providing funding for accredited CME are prohibited from any influence over faculty or content. They cannot pay attendance, they cannot pay attendees or faculty for travel, registration, or honoraria. They cannot influence who can attend. So it really is a firewall between the people who are paying, the pharmaceutical companies, and what's being taught. From our own perspective, scope of pain, which I'll talk about a little bit later, when we look at the participants at the end of the program, we asked them, did you sense any commercial bias? For over 8 years, 99.5% of over 200,000 participants detected no commercial bias, which is actually lower. It's actually better than most CME programs that are not even funded by pharmaceutical companies. So this is good. When we looked at those 0.5%, 20% erroneously clicked yes and then wrote comments such as, "There is no bias in this presentation." And for those who did detect commercial bias, things that fell into categories were, well, the topic's about prescribing opioids, so there must be bias. Opiates are never appropriate when treating for chronic pain. There must be bias. And all pharma-funded CME is implicitly biased. So again, we feel very comfortable that scope of pain is not marketing. It is education that is firewalled between what we're doing and what the companies are paying for. Okay. Then you could ask, well, does CME even work? Well, there were some systematic reviews, that is, again, combining various studies that concluded that CME improves physician performance and patient health outcomes. Not surprisingly, the positive impact was more on patient performance than on patient health outcomes. but you can find both. 8 systematic reviews concluded that the best CME activities are interactive, use multiple methods, involve multiple exposures, are longer, and are focused on outcomes that are considered important to the audience by physicians that will lead to more positive outcomes. So that's kind of not surprising. So how to measure success with a program that's teaching about safer opioid prescribing? These would be the ideal outcomes. These would be outcomes that I would love to be able to measure. That is, does scope of pain, does our education decrease overdoses? Does it decrease overdose deaths? Does it decrease folks going to the emergency department with problems related to opioids? Does it decrease opioid addiction? Does it decrease opioid diversion or giving away or selling their prescriptions? Does it improve clinician performance? Does it improve patient health? That is, does this education decrease patients' pain, improve their function, and improve their quality of life? These would be the ideal outcomes. However, there are challenges when you're doing a continuing education program because there's inadequate data from these participants. We need to limit the burden to them in terms of pre and post-program evaluations, because if you have too much in your pre-program, people are just going to get fed up and say, forget it, and not even take the course. We also have limited access to participants at follow-up. So we want to go 2 months later and find out how they're doing. They're not used to being followed up after continuing education 2 months later, and they really don't want to have anything to do with us. There are difficulties in differentiating the effects of a program like this from all the other things that are happening simultaneously. So has the decrease in overdose deaths related to prescription opioids, which is a fact, which is true, related to our education, or is it overdose education, naloxone distribution? Is it increase in buprenorphine availability for opioid addiction treatment? Is it the PDMP? Is it law enforcement closing pill mills? Is it national state guidelines? Is it insurers that are limiting doses that we can prescribe? So there are lots of things happening simultaneously, and to be able to attribute any of these changes to one thing would be really hard, namely, so it's hard. So what are the more common metrics that are easier to measure, which it turns out that we ended up measuring in some cases, and not all cases? One that's commonly looked at is decreases in opioid prescribing. So is that a good thing or a bad thing? Well, if you look at a population basis, it's a good thing because we were overprescribing. But what's the right amount? Based on what information? Are the changes more judicious or more fearful prescribing? So what is that decrease based on? Improvements in clinician knowledge, attitudes, and confidence. This is what we measured. Improvements in clinician self-reported change in practice. Again, this is something that we measured. These are easier to measure, but they're not as robust as the ones that I said would be ideal. So now, before I get to scope of pain and talk about our program and evaluation, any questions?
No questions at this time.
Okay, I'm going to continue then, and then we can have questions at the very end. So scope of pain. So scope of pain, which is safer, competent opioid prescribing education, has from the very beginning had partnerships. And Jay mentioned the importance of partnerships as kind of a collaborative engagement. And we have felt that it was necessary to partner with different local, regional, and national groups, the Federation of State Medical Boards, the Council of Medical Specialty Societies, academic medical centers, other academic medical centers, state boards, healthcare systems, public health organizations, to just name a few. As was mentioned, we've been partnering with the New England HIDA to collaborate on trainings throughout New England. And our collaboration arose because we actually got started in this kind of education before the REMS program, when our Board of Registration in Medicine came to us and said, we need help. We're getting a lot of complaints about people running into problems with opioids, overprescribing, underprescribing, undertreatment of pain, overtreatment of pain, and so forth. So we started collaborating with state medical boards, state police, and the DEA, and then we found New England HIDA. And that partnership resulted in a 2014 Outstanding Prevention Effort Award from HIDA and the Office of National Drug Control Policy. So we've had a very successful partnership that is ongoing, and it's been great. I'm happy to talk more about what I think has been so beneficial with that partnership. So what about a scope of pain? So we present the program over now 2 hours, and there are different formats, which I'll talk about in a minute, but it's based on a case that's presented. And we teach folks how to optimize safety when prescribing opioids for acute pain, and then to determine when opioid analgesics are indicated for chronic pain. We teach about assessing pain, both acute and chronic pain, and how to assess for prescription opioid misuse risks. So remember I said not everybody carries the same risk for misuse. We educate about educating patients about risks and setting realistic goals and benefits, monitoring patients on opioid therapy for benefits and harms, assessing and managing worrisome opioid-taking behaviors like running out early or showing up in the emergency room because they self-escalated their dose, safely tapering long-term opioid therapy, and then identifying and managing patients who have developed an opioid addiction or opioid use disorder. I mentioned that there are lots of different offerings because different people learn in different ways. We now have an online program that's 2 hours. And by the way, these are all free for whoever wants to take them. We developed a podcast, which is 2 hours in length. It's really 6 20-minute downloadable episodes. We do live meetings. We used to do them in person before COVID, but now we do them via webinar. We have a print downloadable PDF monograph. We have a Train the Trainers program where we would train folks how to deliver scope of pain content to colleagues. And then we've got a bunch of ancillary materials like a trainer's toolkit with videos and case studies. We've got audio micro cases that are like 2 minutes in length that really highlights one key issue. And then we have supplemental complementary education modules like a module on tapering, a module on setting up your practice. And they're all found on scopeofpain.org. I will say that all of the online program, podcasts, live meetings, print are all FDA Blueprint curricular compliant. So how many people have we trained since March of 2013? We've trained 222,588 individuals. The vast majority, almost 2/3, are physicians, followed by advanced practice nurses, followed by physician assistants. What about the specialty of those providers? So almost half are primary care based. Internal medicine, family medicine, pediatrics, adolescent medicine is almost half, followed by surgery and surgical subspecialties, and then a bunch of other types as well. Psychiatry, emergency medicine, and so forth. So how do we evaluate scope of pain? So we published a paper, which I'm going to show you the results in a minute. And our evaluation strategy was the following. Before people, when they registered for the program, we did a pre-program assessment. There were 20 knowledge-based questions. We asked them 6 items on confidence around safer opioid prescribing, 13 items on their attitudes about safer opioid prescribing, 7 items on their clinical performance, like using some of the monitoring strategies we teach about, and then some socio-demographic data. They then participated in the program, and at this time it was a 3-hour program, which is now 2 hours. And then immediately after the program, we did a follow-up assessment where we asked them the knowledge questions again to see if they learned anything. And then we asked them an important question, that is, what is your intention to implement change based on this training? And that has actually been shown to predict behavior change. If someone says, yes, I'm going to make a change, this is the change that I'm going to make, it actually has a good predictive value in terms of whether or not someone will actually make a change. We then followed up 2 months later with these folks and then asked them some knowledge questions again, asked them about confidence, attitudes, clinical performance, the number of changes that they actually implemented, and what some of the barriers were to their changes. So let me show you what we found. So this was published in 2016 in the journal Pain Medicine. And what you can see here is that we had from this, from the following. So we had over 10,000 participants that took scope of pain. We then cut that down to 2,850. And how do we cut it down? We cut it down to folks that we thought should change their practice based on scope of pain. That is, people who are treating patients, people who are treating patients with chronic pain, people who have the ability to prescribe opioids. That is, they have a DEA license. And that brought us down to 2,850. Immediately after the program, 87% had an intent to change their practice towards guideline-based care. So 87% said, yes, I'm going to make it change. And we saw a dramatic increase in knowledge, which I didn't put here. But at 2 months post-program, we tried to follow up with all 2,850, but we only got 476, which is a 17% response rate, which actually for CME is very good. Usually you expect less than 5% response rate. So 17% was pretty good. We then compared that 17% that responded to those that didn't, based on socio-demographic features that we had from the entire sample, and we couldn't see any differences. So from what we could tell, they seemed similar in terms of their specialty, their profession, and so forth. But that being said, it is a lower number, 17%. But of those folks that we followed up 2 months later, there was still a significant increase in correct responses to knowledge questions. 67% increased their confidence in applying safer opioid prescribing care. 86% reported implementing guideline-based practices. And there was an improvement in alignment of their kind of attitudes towards safer opioid prescribing and their care for these patients. And, in terms of, what were some of the safer opioid prescribing practices that it was things like using a patient-provider agreement, doing urine drug testing, doing pill counts, checking the prescription drug monitoring program, counseling your patients about the risks of overdose, co-prescribing naloxone, and so forth. We then decided, the experts that are training in scope of pain, we can only cover so much territory. So let's develop a train the trainers program where we'll train folks to present scope of pain back at their institutions. And we did this. So over a 9-month period in May 2013 to February of 2014, we ran these train the trainer programs. And essentially, it was people who applied to become a trainer. They then attended a live scope of pain program, which was 3 hours at the time. And then they stuck around and we did a 2-hour workshop to teach them how to teach this stuff. And we ended up training 89 trainers from 9 states over that 9-month period. Then we allowed 24 months, 2 years, before we started to evaluate or kind of summarize the data that we got. And we found that 33% of the trainers conducted at least one training, with a total of 79 trainings educating over 1,400 participants. And then we decided, let's look to see if the outcomes are any different for these trainers versus the expert-led trainings, which was basically the first study that I showed you. And in terms of immediate post-training, over 90% of both groups planned to make at least one change toward guideline-based. So again, the intent to change was equally high for both groups. And then 2 months post-training, there was no significant difference in knowledge improvement, improvement in confidence, attitudes, and performance. And one thing we found, which was really good, was that participants of the trainer-led programs were significantly more likely to be practicing in rural settings. So 39% of the participants in these trainer-led programs were from rural settings versus 26% in the expert-led trainings. So we were showing, and we showed that we can actually disseminate this to audiences that may not be able to come to one of our other trainings. So I have some additional thoughts before we get to a final discussion. And one was, I alluded to this issue about, should the training be mandatory or voluntary? And as you know, the FDA made it voluntary based on a lot of pushback. Don't make this mandatory from a lot of physician groups. But you might be interested to know that 46 state medical and osteopathic boards now require some content on pain management for people to get relicensure in their state. So we've compared, we haven't published this yet, but we did compare CME outcomes for scope of pain trainings that were completed by individuals that were in a state that required or pain management training versus those that were in states that didn't. That was purely voluntary. And the CME outcomes that we looked at were immediately post-training. We looked at satisfaction with the scope of pain training, knowledge, intent to change, and perceived barriers to change. The analysis was run on the following subsets. So physicians, nurse practitioners, and PAs that took scope of pain, specialties that were likely to manage chronic pain, and folks who said they prescribed opioids in the last 12 months. The mandatory group were those that completed scope of pain under the New York State mandate. So New York State had neatly just started a opioid prescribing mandate in February of 2017, and we compared it to a voluntary group. That is, folks who completed scope of pain voluntarily from 34 states at the time that didn't have a mandate, or until that state developed a mandate. So as long as it was voluntary, we concluded them. And what we found was that mandated safer opioid prescribing training was absolutely efficient to reach a target audience. However, the attendees from the mandated group were less satisfied with the training, had slightly less correct knowledge answers, and were less likely to say they were going to make a change than those who voluntarily completed the training. There was a weak but significant correlation between satisfaction with the training and the intent to change. So the less satisfied you are, the less likely you were to say, I'm going to make a change in my prescribing practices. And so sending people in, kicking and screaming, saying, I don't want to do it, seeing that individuals had less positive outcomes. The other thought that I have is that it can't be limited to training prescribers, which has been a lot of focus, right? Train focus is to prescribe more safely, but it's a lot of work. And so we really need to train and retrain and utilize lots of other folks that work with these prescribers, staff like nurses and medical assistants, pharmacists, psychologists, social workers. Just like everything else that we do in primary care that's complicated and a lot of work, we need to train and utilize our entire healthcare team. And finally, or close to being final, we must address the complex conversations like that op-ed piece that I told you about. And we've developed a bunch of colleague-to-colleague audio shorts that are a couple minutes in length that deal with things like the challenge of opioids in acute pain, addressing an unexpected urine test results, managing high-risk patients, worrisome signs, and so forth. And we also developed some of these teaching tapes that people can look at that model talking to patients. Again, really focusing on the communication skills. So Scope of Pain, this is our website. Again, go to it. There's lots there to see. It's free. Everything on it is free. We have this new podcast that you certainly can listen to. And we have some upcoming live webinars if you're interested, one in June and one in August. And again, if you go to Scope of Pain, you can register for these live webinars. So I'm going to stop there and thank you.
Thank you. We actually had one question come in, and I know that you've addressed this already in your most recent slide on whether the training similar to this should be mandatory or voluntary. But we did have a viewer ask, just in your expert opinion, what are your thoughts about mandating some course for patient opioid prescribing and monitoring? What do you think?
Yeah, so again, I'm going to tell you what the ideal thing would be. The ideal thing would be that everyone who can prescribe an opioid is competent. That is, you don't need to train someone who's already competent. And so we shouldn't force people who already know this stuff to go through some training. And even if you go through a training, that doesn't necessarily mean that you're going to do a better job. So I would like, if there was some way to measure competency, which is not so easy, before someone gets their DEA license, or when they renew their DEA license, that they are able to demonstrate that they are competent. And it may be, that they need to read some cases and answer some questions, and maybe that's enough. But that's what I'd like to mandate competency for you to be able to prescribe. And I wouldn't leave it to just prescribing opioids, because believe me, there are plenty of people who would say, fine, I won't prescribe opioids. And then we're going to have a problem with access for patients who would benefit. I would say for any DEA license, you should have to show that you're competent. Mandating training has lots of potential flaws, like I just said. You're not guaranteed that people are going to leave and do things better. We hope that they do things better, but if they feel that they were forced into it, they may be less likely based on what we found.
Wonderful. Thank you, Dr. Alford. We're going to transition briefly into our segment on understanding everything that you just presented and some of the evidence in those studies through the lens of the thinking about evidence framework out of the CDC. And to do that, we've invited Dr. Rebecca Bates, who is our Technical Assistance Project Manager for ADAPT, to start that discussion and then hand it back to you for further comments. Rebecca?
Is she on mute, you think?
Let's see. Rebecca, if you're speaking, we cannot hear you. Okay. Patty, do you want to work with her maybe to get reconnected? And I can talk us through some of these slides and get us started in this conversation. So we just wanted to briefly, in our technical webinar series, 3 webinars ago, I believe, we had the CDC come on and really talk us through this framework, which is an oldie but goodie, published in 2011. It's called Thinking About Evidence and Understanding Evidence, and it really takes us through the lens of the research-based evidence and the formal studies, like you've just mentioned, many of them, Dr. Alford, but also it then integrates these other domains of the experiential evidence and the contextual evidence that are so important in thinking through when we implement strategies and even select them before implementation. How feasible is it going to be to implement it in that community? How well received will it be? How acceptable will it be to the population that will be receiving it? And what's the utility? You know, what needs is it meeting? And so this particular framework is one that we really value, and we've even changed some of our language when we speak with technical assistance recipients to say, are you using the best available evidence? It doesn't have to be a randomized controlled trial all the time, you know, but are you using the best available evidence to you when making these decisions and implementing your programs? So what you see here is, let's see, Rebecca, have you joined us?
Okay. Can you hear me now?
We can hear you now. Perfect timing.
Fabulous.
I've just introduced the framework and we've moved on to the continuum, if you want to take it from here.
Okay. So this is an evidence-based best practice spotlight series, and one of the fundamentals for substance use prevention is understanding evidence. What we hope to do with this series is to draw out how you think through each program, practice, or strategy that's featured through the lens of this framework. So this is a fundamental skill that we are seeking to promote and develop by applying it to each spotlight throughout the series, so that there's an ever-enhanced understanding of the way that this works to continuously develop the skill of using the best available research, experience, and context. The Continuum of Evidence provides a framework for evaluating the best available evidence by considering the strength of the evidence and the effectiveness of the program. The framework is structured with the effectiveness of programs on a continuum across the top from harmful to well-supported. The strength of the evidence along the left side of this figure is measured by evaluating the external ecological validity, implementation guidance, implementation replication, the type of evidence and research design, the internal validity and effect. And for a more in-depth discussion of this framework, please see the ADAPT YouTube channel with the recording of the Understanding Evidence webinar. And Patty, I believe you're going to put that in the chat for everybody. So for this particular spotlight, there are several published studies on scope of pain, and they focus on different components of the program and alignment with the needs of the prescribers and the national guidelines, as Dan pointed out earlier. Some of the published studies focus on different populations or the effectiveness of implementation or the methodology behind training the trainer. The ones we're going to focus on today are the ones that focus on the training itself. If you really like the training and you want to become a trainer, we can provide that information again for you. For the purposes of this review, we're going to focus on 2 of the studies that may be most helpful to you. These are the ones you should pay more attention to because they are the most relevant to what you may want to do. So these are the two studies that Dan talked about. And so just to give you a reminder overview, the first article is an evaluation of an opioid risk evaluation and mitigation strategy continuing education program. And this was focused on describing the scope of pain program and the impact on clinician knowledge, confidence, attitudes, and self-reported clinical practice among 2,850 participants. So this study demonstrated an immediate increase in knowledge, and 87% of participants plan to make changes. And the 2-month post-test, there is still a significant increase in the knowledge, the confidence, and reported implementation of practice changes and improved attitudes towards safe opioid prescribing. In the second article, there was safe and competent opioid prescribing education. It described the outcomes comparing trainer-led and expert-led scope of pain trainings. The experts were all physicians with experience as educators, safe opioid prescribing, and publishing. And the trainers, about half were physicians, 20% were NPs, 12% were pharmacists, and 10% were PAs, with varying levels of training in clinical expertise, educators, or minimal to no experience training others in safe opioid prescribing for pain management. So there was no significant difference in the knowledge, confidence, or attitudes, except that participants in the expert group were more likely to agree or completely agree that it is my responsibility and role to discuss with my patients, not to give away medications to their relatives or friends. And participants in the trainer group were more likely to agree or completely agree that I cannot get my patients to be truthful about illicit drug use. So now let's use the continuum of evidence to look at these two studies and figure out where they fall on the continuum of evidence. So, Patty, if I click next, is it? Okay, never mind. Based on this information provided in the 2 peer-reviewed journal publications, scope of pain may be evaluated on these 6 dimensions of the evidence, and those are the things on the left-hand side of the chart. So starting with effect, scope of pain demonstrates short-term and longer-term effects. However, the limiting factor for scope of pain is the lack of a randomized controlled trial or comparison groups. The studies do include multiple groups and have multiple measurement points. And some of the studies evaluated other potential influences on outcomes, such as whether a state requires this training. Independent program replication was done through the Train the Trainers program, with training evaluations of trainer-led outcomes compared to and similar to the outcomes of the expert-led programs. There was a comprehensive program implementation guidance provided through the Train the Trainer program, and additional resources are available on the website with access to expert trainers as needed. And then the external ecological validity is also demonstrated by the effectiveness of the Train the Trainer program in various other settings throughout the country. So now I'm going to hand it back over to Dan and Alana and ask them to talk about how you think through the feasibility, the acceptability, and the utility for scope of pain as you design the program and as you consider implementation strategies or different iterations of this program.
Yeah, so thanks for that. So feasibility, so can it be successful given the resources available? And the answer is yes, as this is grant funded, but we do, we have developed online programs and we have enduring materials that that sit on our website that have already been developed. The podcast has already been developed. There is, some requirement to update it from time to time, but we have built it and it is available and it is freely available. So I think it is feasible, but clearly to develop educational programming like this requires some funding, and educational-based funding is not that easy to obtain, as opposed to some other types of programming that people are willing to pay for. We've been delighted that New England HIDA has been a partner and able to support some of our training, so it makes it more feasible. In terms of acceptability, I think we've shown that with the volume of individuals who have taken the training and the fact that we are still attracting large numbers of people for our monthly webinars. So I think it's certainly acceptable. I think the acceptability piece, you could look at the way the training or the method of the education. And for our study, which I didn't say, but the majority of people who ended up in our study took the program online. So it was like, over 70% took it online. I think that makes it acceptable. If we just did in-person or live trainings, it may be less acceptable. And I think our podcast makes it even more acceptable to certain individuals. And then in terms of, the utility, is it useful for the needs of the people? Again, I think it is. I think the fact that we saw positive changes is reassuring to me, that it's useful to the learner's needs. But to improve upon that, we did another study that we didn't talk about, which was a qualitative study. So when we do our trainings, our live trainings, we ask people to submit questions. Even when we did them in person, we had people write their questions on cards and submit them, and then we would go through them at the end. So we collected those cards over time, and we had almost 7,000 questions that people had asked over a period of time. And we compared their questions to what we had in our scope of pain curriculum, what was mandated in the FDA blueprint, and there were certain things that came out that were different or discordant or divergent themes, like they wanted more on alternatives to opioids. So we certainly have included more on non-opioid treatment. They wanted more on barriers to safer opioid prescribing, namely the amount of time it takes. And that's where we really got into kind of the team approach and the fact that it needs to be not just the prescriber. They wanted to hear more about government regulations and what is our role if we think someone is misusing opioids, or how do we deal with some of the regulations that are mandating clinical practice that we may or may not agree with. There was a desire to hear more about cannabis, the role of cannabis in this whole area. Those states that have it legal for medical marijuana or recreationally legal or illegal. So they wanted to hear more about that. And then finally, they wanted to hear more about the provider-patient relationships, because as I had mentioned to you, it can be quite complex. And when you start to institute universal precautions, sometimes it can seem very punitive to patients and can be a real turnoff and can disrupt the trusting relationship. So it doesn't have to be, but we need to teach people how to do it in a way that doesn't feel that we're judging people, that we're treating them any differently, but basically we're doing it to keep them safe. So, I think we have demonstrated utility based on our evidence. I think there's always room for improvement. I think we have mechanisms in place to identify areas of improvement. And as I mentioned earlier, while we need to adhere to every element of the FDA blueprint, we can still add stuff that isn't in the blueprint. The struggle is keeping it to 2 hours, right? We find that 2 hours is obviously much more palatable than requiring people to sit for 3 hours, and we couldn't do it less than 2 hours. So 2 hours is kind of the sweet spot for us, and so there. Hopefully, I've answered those questions. I will say one more thing. While I think there's still room for improvement, is because we actually published another paper that I didn't mention either, which was looking at, since we've been doing this since 2013, the beginning of 2013, we thought we could look at trends of those people who did scope of pain over the years. Can we see any changes up front? That is, before they go through the training, their kind of baseline assessment of, are they using practices that we're recommending or guidelines are recommending, like urine drug testing, pill counts, and so forth? Can we see some national trend that's happening outside of scope of pain? Because if people are already doing all this stuff now because they've learned about it or they've heard about it or systems have changed to support it, then we don't need to do this training anymore. Well, it turns out that there really wasn't any improvement overall over the years in baseline use of guideline-based patient care for safer opioid prescribing. In fact, we identified one glaring problem, which was that only 28% of folks, when we look at the total sample, was doing all of the universal precautions for all patients on opioids. Many people were doing it for what they called high-risk patients only. And as I had mentioned earlier, we really cannot exclude any patient. Everyone has at least some risk, or at least we should believe that, because there is no tool to identify anybody with 0% risk. So we've got a lot of room to go. And so I think the training is still necessary based on that study.
Thank you, Dr. Alford. I'm sitting here still some of what you were describing related to your qualitative study, and I'm thinking just through the fact that here is a national guideline. You know, you're bringing scope of pain on is a slightly different strategy compared to bringing on like a Botman's life skill, right? Or some other type of established program. You are taking a national guideline blueprint, you are translating it for consumption by the intended audience, right? And oftentimes you're not given that specific guidance or the translation science, right, behind how you should be making that relatable, making it digestible for the intended audience. And what's really neat, and I just want to draw out, is that you have been so thoughtful. You already had successful outcomes, clearly, through your studies. You already had successful outcomes, yet you still went back and you all were very thoughtful in really looking at, all right, among these 7,000 responses, right, what can we draw from this? And while maintaining fidelity, right, to the content that you knew you had to have in there based on the blueprint or the guideline, right? Still, you know, honoring the drivers of that so that we could eventually have better outcomes related to pain management. You went in and you also added and kind of enhanced that training based on what you were hearing from the audience itself. And I just think that's such a beautiful testimony to the world we're living in right now, with evidence and ways that you can make it your own, that you can really respond and continue to integrate audience perspectives and input, while also still maintaining and doing what you said you were going to do with that blueprint, with that guideline, and bringing that critical information to them as well. So I just wanted to highlight that, you know, it's respectable, it's admirable. I can see why New England HIDA has really enjoyed funding you, because you have been a super successful program in that region. And I'm hoping that our viewers today are fully appreciating now through that beautifully articulated presentation, the breadth and the depth of your program and the potential that it has. Did you want to say anything else about upcoming training opportunities or additional resources for the audience?
So there are obviously opportunities, and I'll mention those in a moment. I will say one thing that we learned, which I'm really, really, really proud of, is the latest iteration of Scope has the following change, and that is, we wanted it to be case-based, and it's always been case-based. And when you have a case-based presentation, you're kind of stuck with one ending, right? The case ends in a certain way. You know, there can be some open-ended questions left for that case, but it really takes a single direction. And we got some feedback, and certainly I've always felt uncomfortable with that, you know, people had different experiences, that sometimes patients went in a different direction. So our case now starts as a single case, but at the end, we have 4 different endings, and we present all 4 endings. Some are really very positive endings in terms of the person doing well, and some are not doing so well. And some of the things that, some of the things that a provider could do to address some of those things that aren't going so well. Some require the person to be on a different opioid or to be tapered off the opioid, or even get into addiction treatment. So that's been a real fun part of this program, and I think people have responded very positively towards it. So I just want to put that out there. That was another thing that we learned. But you know, if people want to learn more about this, they want to take a look at it. They want to look at some of our videos. It really is. They're all free. It's all on Scope of Pain. The only thing that you'll be required to do is to register and get a password. Like everything else, it's password protected. But then once you've got your username and password, you can explore and see what you got. And as I tell all of my faculty, if you find anything that you think we should change or anything that you think we're missing, please, please, please let me know. Because we're such a small shop, that is, it's really Alana and myself, we are incredibly flexible. We can make changes to the slides. Again, we need to make sure we don't omit something from the blueprint, but we can make changes to other slides or the way the slides are presented. So I welcome your feedback.
Thank you, Dr. Alford. Just one more kudos to you. We have had through several technical webinars now the discussion around just not only how critical and important it is to really comprehensively evaluate your intervention or whatever it is that you might be implementing for substance use prevention, but just how difficult it is sometimes when you're not an expert at evaluation, you're not a researcher, and I think Jay alluded to this in the beginning, having these strong academic practice partnerships is so critical. But I do just want to highlight again that what you have done in this very thoughtful approach to evaluating the effect that you're having right through taking this guideline is admirable. And you have studied it in ways that aren't necessarily, if you were just to look at the continuum of evidence, aren't necessarily always up there in that top left corner, right? And that's okay because it didn't make sense necessarily to have your particular program studied from the lens of a randomized control trial, right? Based on the various interventions that you have been delivering and the methodology that you chose. And so I just think that's such a critical point to draw out again for the audience, that what you have done with the content that you are incorporating into your intervention is admirable. And I hope that everyone can understand that now through the full framework of research-based evidence, but also contextual and experiential evidence, and have a full appreciation of this is not easy. It's not easy to study. It's not easy to evaluate these types of things. And so I appreciate the effort that you all have put into that, and I'm sure our audience does as well.
Well, thank you very much. And I would be amiss if I didn't come back to the partnership with New England HIDA, which has been very interesting from the beginning. I mean, when you think about it, we really are. I mean, HIDA is known for being, kind of a supply or, supply reduction focus. And the fact that Jay and his group were interested in demand reduction and getting involved in kind of prescriber education. And we learned very early on that should not be front and center, right? Because people are coming to these trainings expecting to hear from, colleagues about how to do this. And if they get up front, like, hey, we're talking about, law enforcement, and people get turned off. But throughout the training, we talk about how important it is to partner with everyone who's involved in this effort. And then, having somebody from the board, having someone from the DEA, having someone from HIDA, it becomes interesting, meaningful, helpful. So it's been a meaningful partnership for us. We've learned how to incorporate it into the trainings that we do. Again, we don't put it up front, but we bring it in at the end when we're talking about how we're not alone, that we're all working together. And I think it's been helpful for folks in HIDA to hear how difficult and complicated it is at the provider-patient level. That it may seem like someone is, being a bad doctor, but in most instances, not to say that there aren't some bad doctors, but in most instances, they're trying to do their best. They're trying to take care of a patient. And anyway, so I just feel like it's been a really meaningful educational partnership for me personally. And I think we've learned how to incorporate it in a way that it's meaningful for the participants. And I think it's been meaningful for HIDA to hear the types of questions that the participants hear that they're struggling with.
Absolutely. And I would even add to that productive. It's been meaningful and it obviously extremely productive, and has definitely, you guys have shared goals, and it's nice to see this public health, public safety partnership come to life through Scope of Pain. So thank you for that. I just wanted to announce before I hand it over to Patty for some final comments on the evaluation that if you have other ideas, this is the launch to our evidence-based practice spotlight series. We've got ideas of ones that we'd like to bring to you, but if you're a HIDA out there and you'd like to discuss maybe sharing your program as well through this series, please reach out to us at adapt@wb.hida.org, or you know me, go ahead and shoot me an email as well, and let's go ahead and start that discussion. If you have other ideas, maybe it's not a program that you're necessarily funding, but you've been considering based on this evidence base, also equally as valuable, please send us that idea and we will begin that discussion. Thank you so much for joining us to this launch. Patty, I'm going to hand it off to you.
Thank you, Laura, and thank you all of our presenters for joining and sharing the value of the Scope of Pain program, especially huge thanks to Dr. Alford. One of the things that I do want to draw your attention to, this is a continuing education event, and even if you don't need continuing education units, we ask that you take a few minutes of your time to go ahead and complete a post-webinar evaluation for us. Let us know how we did, what you really appreciated, any other areas of interest that you may have related to this series. So that will automatically pop up for you on your screen the moment that the webinar ends. After today, you can also expect an email to come from ADAPT, likely tomorrow, that will include a copy of the resource supplement as well as links to how to access the on-demand version of today's webinar. So thank you all for your time and attention today, and we wish you a wonderful rest of your afternoon. Take care.